Hey guys, Don here. Welcome to the $1 Million Minute, where I'm helping you get your practice to the $1 million mark and beyond. I want to do a little shout out today because I got a couple of emails. Once again, I appreciate the emails because that makes me feel like I'm not doing all this work in vain. The first shout out is to Steve. Steve is a few years out of residency, and he said the content has helped him to go from 20 to 26 RVUs daily. I don't really use RVUs, but he says it's pretty significant. So I feel good. I feel good about that. And he also says that he has a pretty busy practice, but I think he's producing more, earning more. So that's kind of the whole goal, and he's been sharing it with some other residencies and some of the residents. So I think a good fit for that is someone that is, I guess, I'm learning this now, that new out of practice that kind of wants to learn to be better and produce more. I think this might be beneficial. Also, I want to give a shout out to Andrew. Andrew said he's been out 1 year in a solo practice, kind of wants to grow it, and feels like things have been going on the right track, trying to implement things. And he asked a question. I want to talk first about this. He asked about using a scribe when it's good to use a scribe. In my opinion, I didn't use a scribe for the first, 13 years. I wish I would have started it early because it earns me more revenue, and I'm more present with the patient, and I just like my job a lot more having a scribe. He asked a couple of things. Do I have an in-person versus virtual? I have a virtual scribe. I have a cell phone in my pocket, and I talk to Murali all day long, and I mute him when I go to the bathroom. And he's like a buddy. I know his kids. He knows my kids. He is in India, and I interviewed 3 different scribe services, and he is my own scribe. He is live. There are some where they record the session and they add it in later. There are some people that use AI scribes, but you still have to copy and paste, and then still have to do all the orders. I kind of like him because he does all this stuff. Now, if you are just starting out and you don't really have good templates, I would probably recommend first making good templates, making your system efficient, because I was very efficient with my EMR first, and then I went into having a scribe. So I was already very efficient. I just wanted to be much more present with the patients. Okay, so shout out to those that sent me an email. Certainly, I'd love your feedback. Send an email, don@podiatrypracticemastery.com. Tell me if you like this. Tell me any questions, and I'll reply to you. I'll reply to these 2 as well via email. Okay, so I'm going to give you the lowdown here. This was my $1 Million Minute. This is from a Friday. So just a reminder, Fridays for me, they're half-day routine and then half-day normal patient. So the routine day, I'm still training Marjorie. Marjorie is a nail tech, but she was practicing this day, not trimming nails, but she was practicing doing all the, putting the patients in, doing the computer stuff. So she was not with me today. On routine days, I do patients every 10 minutes. So usually my appointments are 20 minutes, so we double book every appointment. And I had 33 total patients for the day. And I only do it Friday mornings. Each doctor has a half day that they do nail care. Okay, so I'm not going to talk about all the nail care I do, but I'm going to talk about some of the office visits that I got with the nail care. So just as a way to think about it, not all nail care is just nail care. If there's a new condition, so I had a 80-year-old man, he had some left heel pain, so I did an office visit and I talked about heel cushions and things like that, orthotics for him. That was an office visit. There was another patient, 72-year-old female. She had a callus on the right lateral hallux, and it just kind of comes back and is painful, and I recommended doing an exhaustectomy in the office at a future visit, and this was recommended to her. I don't know if she's going to do it, but I think it would just make her feel better. I had my favorite patient of the day. This was a 97-year-old female, and I always joke. I tend to give my old patients, or the oldest one of the day, I'll give them like a pair of socks or a pair of or a water bottle or something like that. I call it my favorite patient of the day, and I kind of pamper them a little bit. And so I have a lot of freebies I have up front. So I have shoehorns, socks, water bottles, keychains. Actually, they're bottle openers, but I call them keychains. So we have some of those things. Another patient. So those are pretty much the office visits, and I think I did a couple of diabetic foot exams. So just so you know how I do it, I usually do. Let's say I'm doing routine care, like you see them 4 times a year. Once a year, I'm doing an office visit, okay, called a comprehensive diabetic foot exam, but it's usually the diagnosis that I use is the same one that you would use for diabetic shoes. Even though I don't do diabetic shoes, I send them out just because the juice wasn't worth the squeeze, in my opinion. And we're not catering to that. Once again, if you don't want to cater to diabetics or cater to wounds, you don't make it easy. You kind of put in friction, right? So we don't do that. We send them out for that. When I do that, I'll add in like an office visit for that diagnosis. So for example, let's say someone comes in, they might have a bunion, but then they have diabetes. You might use bunion as the office visit, and you're talking about bunions and things that they can do for the bunion once a year, kind of as an office visit. You're not doing this every time. You can also use other diagnoses, like if they have neuropathy, where you talk a little bit more about the neuropathy, talk about Qutenza, things like that. So that would give you an office visit. I try to avoid, if I can, using the diabetes as the code itself. But I have been using it for years, and it does work. So I still get those office visits. I haven't had any issues with it. But once again, this is not an expert on billing. Okay. Then the afternoon. So the first patient was a Lamisil booster. So what that means is they came in. So first visit, nail sample. Second visit, give them 90 days. Third visit, I give them the booster, which entails another 90 days. Usually I send them, I don't know if I said this before, in my area I have a hard time getting another 90 pills covered by Walgreens and CVS. So I tend to recommend them go to either a Stop and Shop or a Walmart for that other 90 pill refill. I do the prescription for once a day for 90 days. But what I tell them, I write it on a piece of paper, is I have them do first 25 pills, 1 pill per week, which is about 6 months, and then the other 65 pills I have them do once a day. And I just found that works, gives a break, because a lot of patients are concerned about being on terbinafine for a long period of time. Also, at the Lamisil booster appointment, if I find that it's not working, I'm not seeing the proximal clearing on the nail, I might switch it to diflucan or Sporanox. He also was taking the biotin and noticed that his nails were going faster, and he opted to purchase a couple more bottles of the biotin. I do have a biotin product I have here, so they get I just find it easier when patients come in. They'll get not only the first prescription of Lamisil, they'll get the UV light, they'll get the shoe sterilizer, and they'll get 2 bottles. And the way I really kind of explain it, and I think I've said this before, is I say, it's $200 for all these things. It's a one-time cost to treat your nails. So that's the way I do it. I do have laser. I just don't find laser as effective. If you are listening to this and you have a lunula, like I do, and if you absolutely love it, tell me, and because I would love to start using it. There are kind of uncomfortable conversations to have when it doesn't work, and maybe I'm just doing the wrong patient selection, but I would love to have everyone that's on oral to be on lunula and see the success. So if you do that, and if you're listening, please reach out to me. I'd love to hear that. Or if you know another person that's doing it, and not just having to tell patients sorry and then transition them, or to people that are doing the laser and Lamisil at the same time. I don't want to do that. I would like to do just one. I wish I could believe in it. I just don't, but I want to. Okay, next patient was an orthotic follow-up. They're doing fine. See them back in 2 years. Next patient this is a new patient, 71-year-old, and this patient had kind of bilateral foot pain, has a bunion bilaterally, has some, on the right side has some arthritis to the second and third metcuneiform joints, and what I recommended for him was a couple of things. I recommended an orthotic to reduce the movement of the foot and the midfoot. I recommended, since he's traveling in 6 weeks, to do a midfoot ultrasound-guided cortisone injection to those 2 joints, just to calm things down. I did not recommend bunion surgery. I recommended anatomic shoes, which I always do, topos and ultras, and along with the orthotic. And I think that's going to be the best thing for this patient. They were not too keen on doing the bunion surgery. So I'm going to see this patient back in 6 weeks to do those injections, and as well for the orthotic follow-up. Another patient for a quick orthotic follow-up, doing well. Next patient was a post-op. This was a patient that I did an arthroplasty of the 5th digit. It was cocked up, and then I pinned it, and so I pinned it for 5 weeks, and I pulled out the pin, nice and straight. I'm not going to see that patient. Actually, I'm going to see the patient one more time in 4 weeks. Just a word about surgery. If you're listening for the first time, I do not do a ton of surgery. That's kind of out of it's purposefully. When I do the surgery, also I try not to do a ton of visits unless it's necessary. Once again, because I'm optimizing for the per visit value for patients, and so I'd usually do a 2-week post-op for suture removal, and then this one was a 5-week to pull the pin, and then I'll do another 4-week one after that. So I know some people in where I train, they wanted them back every 2 weeks to do X-rays. I did not. I don't think that's necessary, and I don't kind of optimize for that. Other patient. This was a patient that came in. She had a previous amputation to one of her toes, and she developed a callus at the tip. I just think she went too long between her visits, and so we just need to get her on a little bit more frequent of a schedule, and I recommended a toe cap for her. Another patient came in. This was a 37-year-old patient. She had, this is the last EPAT visit. So in this office, I had a radial Shockwave, and I'm testing out this new Softwave in combination. So that's an unfocused Shockwave along with EPAT. And then I did the last, which is the third of the sessions, and I did a level 3 office visit. So always the last one, I give them a little piece of paper that kind of talks about what's next. So I consider that an office visit, where I'm going over what the plan is next for this patient for the Shockwave. Now, one thing I am trying to work on. When I went to a recent Curomedics conference, so if you are in doing Shockwave, I would really recommend the conference. They usually do them on Saturdays. There's one in Boston, so if you guys want to go next year, come to see me here. I'm always there. I found it a great conference. And one thing I'm trying to kind of modify my approach is they recommend doing 6 sessions for everyone. I'm currently not doing that. I see the benefit of doing that. It's just changing my conversation. So that's one of the things I'm kind of working on, is to do 6 sessions for all the Shockwave. It's just a lot of visits, and I am not one that's having someone else do my Shockwave. I am personally doing my Shockwave. There was another patient that came in. This was a patient, she was previously seen a number of years ago. She had a left ankle fusion, and this is by another doctor, and she had left plantar fasciitis. And so for her, I did a left plantar fascial injection. I don't do a lot of injections. You probably listened to that, but I did one for her because she had good success with that in the past. And on her right toenail, she had a nail problem, so I did a nail avulsion. I'm not going to see her back unless there's any other issues. Once again, this is a way that I'm kind of doing it to reduce the low value visits. I'm available to her, but I'm not having her come back. Another patient came in, a 27-year-old female. She had been treated for kind of over a year for warts by different doctors with salicylic acid, with freezing, with cantharidin. Really didn't get better. I did for her Swift number 1, went over kind of the treatment options, and she opted that. So it was an office visit with Swift, and I'm setting up, I usually do 3 to 4 Swift treatments for that patient. Last patient of the day was a fracture follow-up. She was having a hard time moving her toe. She was a nurse, so she was kind of concerned, so I saw her back. But she is doing better for that. Okay, so those were the things of the day. Once again, if you have any other things that are working for you, I'd like to, I was talking today about nail fungus. I know it's not the greatest thing to talk about. I would love to know if anyone has a really kind of great profit center with nail fungus and how you do it. Kind of your visit 1, visit 2. I'd love a way to make it more, financially profitable, because we all see so much of this. And if you guys send me what's working for you, kind of your wording, what you do for visit 1, visit 2, visit 3, things like that, anything you do to make it more profitable, I will put that all together in a document, and I will email it to everyone, or I'll do a podcast probably about it as well. But I just love to know kind of what's working for you, different than kind of what I do. So let me know about that. Okay? Okay. Have a great week.